Cue point. There we go. Look, we're all. Why are we all watching Jenna? Okay, there we go. So we are doing our personalities this evening. Making our link in there.
It's still like spicy.
All right, we are up and running. So we're going to make sure we try and keep it to about an hour. Take a break. Get through this material. And then we'll have questions, and then we'll hit as many different things. I'd like to hit the personality disorders and then review some other material tonight as well. So let's start at the beginning, because that's what we need to do.
Yeah.
Now, what is a personality disorder?
A learned behavior.
A learned behavior. What does that tell you has occurred?
They've learned how to act that way.
Mm-hmm. So can they, like, did it just happen when they were 20?
No, it's something that's happened their entire life.
Yeah, it's a totality, a collection of personal traits that becomes fixed, rigid. Person experiences inner distress and behavioral dysfunction. So what's the personality? Our personality disorders are a collection of personal traits that are fixed and rigid, so things that aren't going anywhere, that the person experiences inner distress and behavioral dysfunction. So, what would be personality, though?
The self-identity from experiences and
Yeah.
that have influenced their life.
Yeah, your identity of self-concept. Who you are over time is your personality. So totality of unique biophysical characteristics consisting of influence, inner experience, behavior across lifespan. Again, self-identity of self-concept or who you are over time. And when we're talking about these disorders, most of these are a learned issue, correct? When we're talking about disorders in general, but personality disorders are learned. When do we normally diagnose a personality disorder?
Not until we're 18.
Yeah, when they're an adult, young adult, 17, 18.
17, 18.
But are they going to show signs or symptoms of this stuff earlier?
Yes.
Yes, yes. And that's usually where we try and catch on to this. And one more definition we think about: enduring pattern of inner experience behavior that deviates remarkably from the expectations of their culture. When are we defined? At what age do we become who we are?
5.
5. At the age of 5, we're done. We begin deviating from that 5, we start having issues. So let's begin talking about our personalities. A, B, and C. We're talking about the disorder clusters. Okay? So, A. What are our terms for A that we're using?
Odd.
Odd.
Eccentric.
Eccentric. Your two big words to define these. Every single one of these will be odd and eccentric. Every single one will have this as part of your 3 personality types. But then each one of them has their own unique things to separate them. So as you think of them as odd and eccentric, it kind of keeps them separated from B and C. The nice thing about A doesn't care what people really think about them. A is very unique about that because B and C does care about that in its own unique way.
South Doyle High School, where for the moment.
So, A, odd, eccentric. So let's go with our B now. What would B be? What are our terms for B?
Erratic, dramatic.
Dramatic and emotional. Those are our two things. No matter what be, they will be dramatic and they will be emotional. No matter what be you choose. And then for C,
Loners.
they can be. Not necessarily fully defined as that, though. They may be forced to be a loner, but they're not loners, not all three of them.
Anxious and fearful.
Anxious and fearful. Remember, dependents are C. They're not loners. They don't want to be.
Jenna, stop looking at your notes.
Now I learn.
Okay, let's go through these. So, proposed personality disorder categories are depressive and passive-aggressive disorders. Then we also have nursing interventions, which we will go over later. So, etiology, our structure disorder, represents variants of the normal personality structures rather than disease processes. So, learned behaviors, can we get them out of this?
You catch it early.
We catch it early, yes.
Don't touch your eyes. Keep this.
Others claim that psychosocial factors such as abuse, neglect, trauma, inadequate parenting, all things that we've talked about.
Don't touch your eyes. Go wash your hand by soap. Don't. Go wash your hand by soap.
The personality disorders. Still others should nature versus nurture, responsible for producing personality disorders. So again, psychosocial. The idea for etiology is pretty simple, though. All three of these is throwing the ideas. However you're brought up can lead into one of these disorders if you're not brought up correctly. So if you're abused as a child or neglected as a child or any of these issues can lead into this. So let's say, for a quick definition, our mind. If our mind became multiple personality, what do you think happened?
You still have a dominant one, but the others will take over in certain situations.
Right. The idea there is
like a defense
our mind.
mechanism.
What?
Like a defense mechanism.
Exactly. Our mind couldn't handle it. The abuse. So it made something that could handle the abuse. It made that second personality. And once again, remember, these are disorders, not diseases. So if we're giving medication for this, what are we treating?
The symptom.
Symptoms.
Symptoms. Onset clinical care. When do you start seeing symptoms of this?
Adolescence.
Early adulthood, early childhood, or adolescence, depending on the disorder. But again, we don't diagnose until when?
18.
18, 21, right in that early adulthood range. Because the personality is completely developed at that point. Inpatient setting, personality disorders are about 30 to 50% of the population. You're going to see a lot of the criminal population. The majority of them have these disorders. And, a majority also have a history of alcohol and drug abuse. The drug abuse, with the alcohol and drug abuse, could be anger management, coping to escape that reality. Now, these are personalities, but they're causing issues. What do you think their thoughts are about treatment?
They don't need it.
But they don't need it. There's nothing wrong with them.
There's nothing wrong with them. Every one of these, there's nothing wrong with them. It's not a disease, it's a disorder. This is how they think. Therefore, they're fine in their minds. The behavior is deeply ingrained. Nothing is wrong with behavior. It's everyone else. And it's always someone else's fault. For psychopharmacology, we can use medications such as lithium, anticonvulsants, mood stabilizers, and benzos for this, depending. If they're depressed, we've got SSRIs. If they're delusional, we've got antipsychotics. Treat the symptoms. It's our major idea here. Whatever the disorder is, find the problems and treat the symptoms. So, it's just like any other person, though. We need to build trust with this person. Focus on building that trust. And depending on what it is, we need to focus on teaching basic living skills, provide support, decrease the stress, and improve interpersonal relationships, because every single one of these disorders make it difficult for them to have interpersonal relationships. Positive interpersonal relationships. We can use relaxation and meditation to help them reduce their anxiety. Why are a lot of these disorders, why can't they establish a good, strong relationship? Majority of these disorders.
They are suspicious for everything.
If there's nothing wrong with them, there must be something wrong with you.
Right. They can't trust themselves, let alone anyone else, though.
But they don't know there's anything wrong with them.
Mm-hmm. So they're not going to trust anyone else either. That's just how some of these work. All right, let's move into these actual clusters. So again, what do we say about A?
Odd, eccentric.
Odd, eccentric. Okay? These are the ones that do not care if you like them or not. They're just like, I'm going to go over here now. Our first one, paranoid. What are they going to look like?
Disheveled.
Okay, we can. When you're talking to them, how are they going to talk to you?
Scared and timid.
Can, yeah.
Suspicious.
Suspicious. They
They're,
don't have.
I'm sorry, they're easily offended.
Yep, and they don't have to be. They don't have to necessarily be timid, though, Mike.
Well, right, but a lot of times they are.
Right. The other thing is they can easily fight back and counterattack you for just saying something to them.
Timid and so.
These ones are, remember, odd, anxious. They don't like to show emotion. These are paranoid. They kind of sit back, don't stay. If you get on them, they'll show emotion on you.
What are you looking at?
Exactly. They cannot acknowledge their
Don't ask
negative
that
feelings
question,
towards
Jim.
others. They project their negative feelings. They don't have many friends, and they're quick to react with anger and counterattack in response. How would we intervene? What are our nursing interventions for these guys?
Formal business-like manner.
Formal business-like manner, okay? How are we going to talk to them?
It's a matter of fact.
Matter of fact, that's our big one for them. Direct, almost confrontational. We need to keep our promises with them. We're going to be there at 9:30. We're there at 9:30. Don't be there 15 minutes early or 15 minutes late. Refrain from social chit-chat and jokes. Be on time. Keep your appointments and promises. Those ones aren't too bad. Okay. They do not show a lot of emotions with paranoid, but when they do show emotions, it's because of the paranoia. Okay, so that's paranoid. Simple enough on that. Back to A again. Odd eccentrics for A. Let's move on to schizoid. The geek in the basement. Schizoid. What's that?
Very indifferent. They like to be alone. They prefer it.
Yeah.
That's their neck beard.
Neck beard.
Neck beard.
What a horrible thing to say about somebody.
Oh,
You are a horrible person, and you are not allowed on here. What a thing to say. Jeez.
I'll see you when you get here.
Ring a ring a ring a ring. So, and this might help you guys a little bit. Let me do this. Think about this screen right here as we're going through this. Schizoids, okay? So what do we know about them? What do you think they're going to present to us?
Being isolated.
They're going to be isolated because why? Are they forcing themselves into isolation?
They like it.
They like it. Not forcing it. They're like, give me the basement. I want that. They're indifferent to social relationships. They have a flattened affect. Cold, unsociable, secluded. Never married. They have loss of interest in their sexuality. They are adult children with their parents. They're lifelong loners with solitary jobs. We thought of these as neckbeards, as our friend said, and we also said cats. Cats are schizoids.
And her cats.
Now, for nursing interventions, what would we want to do with them for activities? We want to bring them into a group?
No.
No.
They're going to pick up their game and walk away. Where's the best place for them to live?
With their parents.
If they're a mental patient, we can't have them live with their parents. Where would we want to live?
Long-term care.
Live in a broad care facility, yep. Somewhere that will provide their meals for them and require a little social contact.
They can still live with their parents.
They can, but if they had to live somewhere,
Oh, I
like
see
an
what you're saying.
inpatient. The idea is somewhere that would make things for them, food, etc. Give them the things they need. What's the difference between a schizoid and a schizophrenic?
The delusions.
Delusions, that's right. They're the actual psychosis.
Schizoids know they're isolated. They don't care that they're isolated. Schizophrenics don't understand that they're isolated.
Yeah. Schizophrenics don't know they're isolated. Schizoids they know they're isolated and they don't care. What would cause somebody to become a schizoid?
Being rejected a lot as a child.
Socially rejected as a child, right?
They start
Now
to become fearful of rejection.
Yep, now they just don't want to socialize because they're afraid of that rejection. And if we ask them to go to group, it's a waste of time, right?
Mm-hmm.
All right, moving on to schizotypal. So we had our paranoid, which is one of the easier ones to think about. Schizoid.
What's our communication with schizoid? Did we go over that?
Oh no, we looked this up. Get a caseworker.
That's right.
That was the book's definition. Get a caseworker.
So we cannot communicate with them, that means?
Nursing interventions for schizoid included get a caseworker. Very few communication styles will work because they're just going to walk away from you and go back and be secluded. This requires a multidisciplinary thing to handle schizoids.
Yeah, you pretty much make sure that you provide their meals and they're taken care of.
Mm-hmm.
Okay, thanks.
Mm-hmm. Now, schizotypal. What's special about schizotypal?
They're very odd and eccentric. They talk to themselves.
Say odd and eccentric defined paranoid and schizoid.
They've learned their behaviors from a schizophrenic parent
There you go.
or relative.
Learn from genetic parents. Yes, a relative usually around them. It's again learned behavior. They've seen it, therefore they've learned this behavior. With a high risk of psychosis, extreme discomfort, intolerant for close relationships. Disturbed thought patterns manifest odd behavior, speech, and appearance. Superstitious, believe they're capable of unusual forms of communication and linked with schizophrenia.
Magical thinking.
Yes, magical thinking. They also have the ability to think that the TV is telling them messages. What was that?
It's a reference.
Ideas of reference.
Ideas of reference, right? We're going to give them medications. You could give them antipsychotics to help with these delusionary thoughts. Now, these guys, we may have to help them with their self-care. Behavioral, if they're having issues, what you could do are psychotropics. Now, in general, we're talking about these types of medications. Just think back to our atypicals really quickly. If our atypicals are working, what are you probably going to see happening? Not for schizotypals, but just in general. If atypical medications are working for a patient, what's one symptom you'll probably see occurring?
They're going to gain weight.
They're going to gain weight. Yep. And we like to use atypicals because they have a decreased risk of the extrapyramidal side effects. All right. Interventions. What are we going to use for schizotypal? These guys that are like, woo, free beer, think about, I'm going to control everyone.
They have to take care of themselves.
Yep. Got to aid with self-care, social skills. Help them establish a daily routine.
David, would you clarify more about its learned behavior you said?
You want to guess how we're going to talk to these ones, Jennifer?
Through the TV?
That's a good one. I think that'd be an amazing idea. Hey, you, listen, you're nerds. All right.
That's pretty good.
So again, A was our odd eccentrics. They include paranoid, which that's one of the easier ones to remember, schizoid, and schizotypal. Schizotypal is based on a genetic thought because it's usually this is all learned behavior, so therefore someone in their family would have schizophrenia. Schizoid, living in the basement, they're not going to really do much, and they're going to want to stay down there. Cluster B, dramatic, emotional. Okay? So, moving into cluster B, let's start with antisocial. Alright? These aren't the ones that sit in the corner, these are the ones that are against society's rules. So, what are you going to see in an antisocial patient?
No regard for other people's.
No regard for other people.
They can be superficially charming, but they're kind of like the rule breakers.
Salesmen. Politicians.
Politicians.
They're aggressive, irresponsible. Usually involved in criminal justice system, young age. Involved in fighting, lying, and stealing, with abusing children at school age, and as an adult, they'll abuse spouses, abuse drugs, and participate in confidence schemes. And again, superficially charming, lack the genuine warmth. Children, you'll start seeing them constant parent fighting.
You guys couldn't hear me screaming, could you?
No.
Okay, good.
Why were you screaming?
I had some. April went to Chili's last night and brought home some of those honey chipotle wings.
Oh yeah.
And the celery was covered in it, and I went to bite the celery, and it bent in half, and then shot me in the eyeball with the sauce.
Ouch.
Yeah, so I had hot sauce in my freaking eyeball.
Antisocial. Constant negativity. Angry. I. All about I. I have to win every game. It's about her son saying, I have to win every game. It's all about the I for them. But who can help these people?
A role model, positive role model.
Positive role model, someone to mimic. And again, what age would you diagnose this?
At least 18.
18.
18. But you'd see history of this before 17 years old. They may be in and out of juvenile system around the age of 12 and beyond.
But the positive role model is only going to help them if you catch it early when they're in a
Catch it super early, yeah.
Yes, correct. If that 12, 13-year-old is starting to show it, get them then.
Gotcha.
You get them at 35. Here, let me show you this 20-year-old in Big Brother. No. All right. What is happening anatomically for antisocial?
They have less gray matter.
Yes. Where?
Their prefrontal cortex.
Yes. And that's where our personality is. Also controls, regulates behavior, and suggests, and then therefore it suggests a genetic contribution. So, what's their mood gonna be?
Antisocial.
That's not a mood. Anxious. And their affect?
Angry.
Angry. Fear can be masked, though. They'll manipulate the situation to his or her benefit. Treatment over jail, sad childhood. They're going to manipulate to whatever is best for them. If jail is best for them at that time, then they'll manipulate to do that. Treatment may be better for them at that time, they'll go to the treatment. But if it's treatment, say they have to go to, like, anger management. How long will they go to the anger management?
As long as it benefits them.
Right. If they have, let's say they're an alcoholic, and they go to the Alcoholics Anonymous, they're ordered to go there for a year. How long will they go?
Only as long as they're ordered for.
That's right. That was fun. Let's go back to my Monday night bar hopping. Thought process. Organized or disorganized?
Disorganized.
No, they are organized.
Organized.
This is organized?
They're organized. Their thoughts are organized, and they know what they like and don't like. The world's narrow and distorted. It's all about I.
Oh, okay.
But it's all organized around the I.
You say it's really organized and they have above average intelligence usually.
Mm-hmm. They're average or above average IQ, exactly, with their sensorium intellectual. Judgment.
Poor.
Yeah, poor judgment. This is your idea. So your thought processes are organized, but your judgment's poor because of the I want, I. Self-concept, self-esteem.
They have a poor self-esteem, don't they?
You're superficially confident, self-assured, and egocentric, but shallow and empty. The whole idea is protect yourself. Remember Titanic? We were talking about that. We used Rose's fiance as this guy. Oh, we used him as the narcissistic.
I must have missed that.
He was a narcissist. He wasn't antisocial.
I thought
but remember, everybody's got a little
we were using Milton and the boss.
Yeah, say he's more the narcissist, not the antisocial. Excuse me. Roles. What does he do to others? The antisocial. He's against social norms. So what does he do to others?
Manipulates them.
Manipulates them. People kind of go around the idea of we all kind of work together. He manipulates that. He's unable to make a personal commitment to anyone. Why would he seek treatment by himself?
Only if it benefited him.
That's right. Whatever reason would cause him to gain from.
I'm trying to think of why they would actually do that. I was like,
personal gain. Something that would give them personal gain.
They may be in a relationship, and that person is.
Okay, they said, unless you go, but that's still not them seeking it out on their own.
Yo, that is. That's like, if you don't do something for this, we're gonna be done. And they're like, all right, and they go and do this and do everything they're saying. They've just sought treatment.
Okay.
And that's they're doing it, quote unquote, on their own because it's for their
Oh,
benefit.
because it's not like court ordered or I see what you're
Yeah.
talking about.
They may be in a relationship, and the girl may be threatening to kick him out. He pays for everything, and he's like, oh, I'm gonna change, I'm gonna get help.
Yeah, manipulator.
Mhm.
So, nursing diagnoses for this.
Anger management.
Was it risk for other directed harm or something like that?
I say anger management is not necessarily a nursing diagnosis that I know of. Yeah, risk for other directed violence.
Anger is a nursing diagnosis, right?
Anger management would be an intervention or something to get them there.
Mhm.
But yeah, risk for other directed violence, ineffective coping, and ineffective role performance. They're antisocial. They know how to manipulate out of their role. And how to, not have to deal or cope. What's their outcome if they actually reach that 17, 8-year-old age and they're actually antisocial?
Pretty poor.
Yeah, it's pretty poor. They're probably prison bound at some point in their life. We need to focus them on behavioral change, but is that normally successful at that point?
No.
No. No. It's not. When we are, let's see, when we're forming a therapeutic relationship, what type of environment should we put them in?
A solitary environment.
Structured. It's close enough. Not solitary, but structured.
But you don't want them around a bunch of other people to manipulate, yeah.
Yeah, you don't want them. Yeah, you want them around some people, but they're not one-to-one.
You don't allow them to manipulate.
Correct. You need to identify acceptable and expected behaviors, give them consistency, set limits, and confront them when the limits are not met. Now, when they have problems to solve, who's going to solve them?
You got a problem, I'll solve it.
Okay. DJ revolves it.
Is this one where they need to solve it? Because if you do, they'll blame it on you.
Yes. We need to help them so they make a decision. To help them practice problem-solving skills. We can help them enhance role performance, identify problems in relationships. This is the one where we encourage them not to have relationships until they can self-care. Care for themselves. Help with behavioral changes. Are they going to change all their behaviors?
No.
No, they're not. But even one permanent change is better than none. We put the evaluation, we look at the progress towards our outcomes. They're not going to meet all their goals, but one positive is better than none. Now, how do we communicate with these?
Correct. Matter of fact.
Confrontational.
Matter of fact, we're going to use confrontation?
No.
No.
Yes.
If you want to start a fight.
I'm bigger than they are.
We're going to lay clay on them and be like, now fight. Direct, matter of fact, what else?
Isn't direct kind of confrontational, though?
Direct conversation, like this is what's going on.
Which is confrontational.
Part of matter of fact, no. Confrontation is when are you doing it, why are you doing it, or not why. When are you doing that? Why thing likes to pop up when you're first not used to saying that.
Just letting them, the behavior is not acceptable, right?
Direct, matter of fact, give consequences. What are you not going to do?
You're not going to praise them.
You do not praise. They want the praise, you do not give the praise. When they're doing something they're supposed to do, you don't praise them. You also don't allow them to manipulate. Let's... All right, so that's our idea of antisocial. The cluster Bs are the ones that are busy. They have a lot of information to them. Cluster Cs and cluster As are not nearly as busy. So that should help us realize that A, B, C, an A and C, there's not much information that we have to realize. Just B has a lot to it. We can kind of pull those apart. That'll help. So we've just done antisocial. Let's move on to borderline. Think of a borderline, and most of the symptoms will fall into that thought pattern of a line with something on one side versus the other. So, borderline, impulsive, self-mutilative, manipulative. So, again, early adulthood, you'll be seeing evidence of the instability, impulse control, and interpersonal relationships. Instability in impulse control and interpersonal relationships. Their behavior is labile, unpredictable, erratic. View life and people in extremes, such as all good or all evil. And these are the ones that split the staff. Most of these are what?
Women.
Women. They view themselves as victims, assume little responsibility. If they're being ignored, what are they going to feel? Click, click, click. If they're being ignored, what are they going to feel?
Rejection.
Angry. Inappropriately angry. There's that. Inappropriately angry. If they're not getting attention, what's one big way that they try and get attention?
I mean, try to harm themselves for these
So self-harm.
Yep, self-harm, self-mutilation. Do they want to die?
No.
No. Those are the ones that call after they attempt.
Okay. What kind is it?
Robert, I'm going to teach you.
Okay.
If you're going to move, mute yourself.
Yeah.
Identify disturbances regarding self-image, sexual orientation, long-term goals, and career choices. Now, what do they have a history of, if this is the case?
Okay, you said it was a 2011 with 70,000 miles?
Whoa, whoa, whoa. Amy, you're on.
I see.
Oh, I was like 70,000. What?
These patients are inappropriately angry if you're ignoring them. They're unstable. They're impulsive. They want things. They want these patients. They want to be looked at. So, what history would they have?
Don't they have a history of abandonment?
Yes, abandonment, usually maternal. So at the end of that borderline, or a line, would be mommy. Act out to get the attention or love. Never believe in love being shown forever, so they need that constant reassurance. So they're constantly running down the borderline to get to mommy, and they're never getting there. The never-ending line, borderline. What sexual orientation are they?
Love the one you're with.
Love the one you're with. Love the one who's showing you the most attention. My plant shows me attention. Okay. with borderline, what else could be occurring as a child, even 18 to 30 months of age? So mom could disappear. What else could have happened?
Is that some kind of assault?
Yeah, sexual, physical, verbal abuse. 18 to 30 months of age as early. Parents may also be alcoholics. And they brought this up, Jen brought this up the other day. That's also the Erik Erikson's autonomy versus shame and doubt stage. So that kind of links into that. So, again, borderline, thinking both sides now. What's their general appearance at this point?
They're disheveled also.
Disheveled. What are their emotions going to be like?
Very
Labile.
erratic.
Yeah, labile. What about their motor skills?
Normal.
Normal.
Yep, normal. What's their mood?
It depends.
Exactly. So what's the term for that?
Dysphoric.
Dysphoric. Happy, sad, unhappy, restless, malaise. Can feel empty, but very rarely happy. So, thought process. What is the reason for the manipulation?
Fear of abandonment.
Fear of abandonment. Their great fear of abandonment causes them to manipulate to keep people coming to them. People can't handle that, and it pushes them away further. They'll they'll disassociate and cause harm to themselves. Transient delusions, they can come and go. Hallucinations. Psychotropics can help with that. What's their sensorium? What's their IQ?
Average intelligence.
Yep. What about their intellectual process? What can happen after any sort of abuse?
It kind of regress to that age.
They can during flashbacks.
Flashbacks.
Flashbacks, yeah. All right, judgment.
Poor.
Yes, they're poor. These are borderline, right? Left, right. Think of the borderline again. They participate in what type of behavior a lot? Risk. So if I put all my money over here, I can move over the line a little bit. And gambling, reckless driving, shoplifting, poor impulse control. They do not think of the consequences of trying this. So if I put 4 months of the mortgage right here on number 2, and I win, I can pay off the mortgage. Self-concept.
Have low self-esteem, low everything. Low
Yeah, low
self-image.
body image, low self-concept, low self-esteem, low identity. They're needy, dependent one moment, and hostile, rejecting the next. Suicidal attempts, self-mutilation.
I know that this is like self-mutilation, but I wrote this down like 3 different times while she was lecturing, that they're always swallowing things. So that may be important just to think
Yes, it's a
about.
type. Yeah, they like to, they'll eat something to get that, to get them. They'll swallow something.
Getting attention, going to the hospital. Oh, you got this stuck in me.
But I'll write that in there as a little reminder of that, because she did mention it more than once. Swallowing. Okay. Roles and relationships. What's going to be going on with that?
And very stormy relationships.
Stormy,
Unstable.
intense. Can they be alone?
No.
No. Relationships are unstable, and they hate being alone, but behaviors will force them away. Physiologic. Self-care. What are they going to do? Can they take care of themselves? Are they capable of taking care of themselves?
No.
They're capable of taking care of themselves as long
They
as they're
want
not
somebody else to take care of them.
Yeah, but they want somebody else. So, what are they probably going to do if they've got drugs available?
Overdose.
Overdose, drug abuse,
They're going to swallow
binging,
them.
purging. They're going to do anything for attention. Here we go, Jen. This is where I wrote it. Swallowing things. overdose. Calling after suicide. So our nursing diagnoses risk for suicide.
They call before a suicide attempt. I'm gonna kill myself.
Yep. Or I just swallowed all my Ativans before they swallowed all their Ativans. Risk for self-mutilation, risk for other directed violence, ineffective coping, and social isolation. Goals of patients based on those diagnoses are pretty self-explanatory. Interventions, long-term psychotherapy to address the issues of family dysfunction. Inpatient admission during that crisis, then outpatient for work on the crisis, on the issues. How do we communicate with a borderline?
Empathy.
Very
Empathy.
carefully.
And praise.
You confront.
Praise, right?
You confront.
We do praise for that.
You give exploring and observation. Also.
Yep. Empathy, explore, observation. You give them praise.
Reassurance.
Huh?
Reassurance
Reassure them for what?
that you're gonna come back.
Yes. Or they're gonna be on that call light, or they're gonna hurt themselves. What do we not do with a borderline?
Don't put them in with another borderline.
Don't put them in group.
Well, yeah, it's going to be hard to put them in with the groups, but never have two on the same floor, but never confront them.
Okay.
So again, if you consistently think of a borderline as on an actual borderline, everything falls on that. You confront them, they'll fall off the borderline. That's a bad thing. Reassure them, showing them. Empathy, explore, observation, praise them for doing what they're supposed to do. Promote therapeutic relationships, like things like don't let them split the staff. Establish your boundaries, what's acceptable and what's not, and talk to them in a matter, tell them this is not acceptable when they try to do something like that. Teach effective communication skills, help patients cope and control emotions, reshape their thought patterns, structure their daily lives. You can give them timeouts if necessary. And evaluations. Now, why don't we, it's been an hour, why don't we take, before we go to the last half, why don't we take 10 minutes off?
Good.
Take a 10-minute break?
Okay.
Okay.
10 minutes.
Can you hear me, David? Right?
I'm sorry, Mike.
Can
Why
you
are
hear
you
me?
sorry?
You know.
I don't know. You mean about tomorrow?
Yeah, no, yeah. I know it's supposed to be today.
Yeah, it happens. She's just annoying.
Dancing. Oh yeah, don't dance. I just remember we're online. Dancing.
Oh. I'm not gonna make it.
No,
Ugh. And I'm running. And still running. Freezer. And still running. And still running. And still running. Oh my gosh, you gotta be kidding me.
Well, by what's up? Ready?
Wait on you.
Oh, I'm sorry. All right. So, be good to go with this then. So, let's move on to the histrionics.
You mean the Daves?
Absolutely. For the most part. I'm not all of them. So, long-standing pattern, excessive emotionality, attention-seeking behaviors. Strive to be the center of attention. Focus exclusively on their own desires, interests during conversations with others. Often dress provocatively. Express themselves in dramatic and highly emotional ways to get attention. Engage in seductive behavior to get approval. Mostly in women. Speech is colorful, theatrical, but little details. They'd seek treatment for depression, unexplained physical problems, and difficult relationships. Experience rapid shift in moods from laughing and crying. What would be their mood?
Labile.
Labile. Why would they be labile?
Because they're constantly changing.
So if I'm talking to you and you're upset, what would you expect me to do if I'm a histrionic?
You're going to be upset also.
If that's the mood that I think would be helpful, I could change to an upset mood. If you're happy, I could switch to happy. Refer to all acquaintances as dear friends. Give patients honest feedback for nurses. We need to give them honest feedback about their social interactions with others. They want to be a people pleaser. They will do anything to be loved or to prove they love someone. So, let's say they show up to class all weird looking. Mike, what would you want to say to them?
Send them a text message telling them that they're weird.
Yeah. Yeah. And if they're a true histrionic, what will they do?
They will change.
They will change.
All right, Dave, you're definitely not a histrionic.
All right. Communication. Honest. What else?
Observation.
Observation. Remember, the big thing on histrionics is they try to please others.
One of the things she said in class that I didn't really follow her, she said that they may say something about like being a director of a Broadway show.
Lying.
They lie.
Mm-hmm. Uh-huh. Hey, go, Mike.
We're the director of a Broadway show.
They're big storytellers. They'll tell you big stories so you get to like them.
But then you'll be like, what Broadway show? Oh, don't worry about
That's not important. We'll talk about the other stuff, though.
They try to say stories that are going to impress you.
Okay, that makes sense.
Like if you're an actress, oh, well, I was this director and I produced these plays and blah, blah, blah.
Mm-hmm. Again, if your mood, if you're upset, they'll switch to upset. If you have something that they can, try and relate with, they'll try and relate with it and lie if necessary.
Like Dave likes pirates. Oh, I love pirates. I have my own ship. I played Captain Jack Sparrow in Disney World.
I'm on my way. Don't say that to me, my heart. Yeah, that's why she brought that up. The idea of they're good at, not necessarily good at it, but they lie. Try and get people to, again, Do anything for people to be pleased. They're trying to please others, to feel that love.
Coffee time?
Yes, please.
Oh, I'm sorry, April.
No, you don't say that to me. Feedback focused on the appropriate alternatives. Discuss social situations, others' perceptions, reactions to their behavior. Help them look at their personal strengths. Convey confidence in the patient's abilities. See, there's me, if you want to think about that, and then I've already realized that that is that. So it doesn't matter. So, histrionics are the ones that want everyone to like them. Then we move on to the narcissistics that make everyone lower than them. How does that work?
They use people and take the credit for someone else's hard work.
That's part of it. How do they communicate to others?
Oh. They belittle them, don't they?
Very condescending.
Mm-hmm. That's right.
Well, hey, David, you'd say condescending. You don't know the meaning of the word.
Condescending.
Never mind.
They would say something like, "That's why don't you take a look at their grades compared to mine?"
I've never said that.
Hmm.
Never have I said that. Never have I said that.
Mm-hmm.
Never have I said it. You can quote me. Lifelong pattern of self-centeredness. Lifelong pattern of self-centeredness. Self-absorption. Inability to empathize with others. Grandiosity. Extreme desire for admiration of others. They're unusually special. Often exaggerate their accomplishments to appear more important. Despite their grandiose ideas, what's their self-esteem like?
It's low.
It's fragile. Easy to straddle that. Overly sensitive to what others think or say about them. It could be high, but it could be very easy to bring them down.
That's true.
How do they feel about others' needs?
They don't care.
What about empathy?
They don't have any.
They're going to make sure they feel big by making others feel small. If they're the boss, they're going to take credit for what you did. If it was something good, and they're going to make sure you know if you did something wrong. They may display arrogance or haughty attitude. Will take advantage of others for personal gain. Their thought process, what's that for them?
I'm all about themselves.
It's intact, but it's limited. The insight's limited. So it's there. Their thought processes are working, but it's all, what can I get for me? Insight's very limited. They view their problems as the faults of others. Difficult working with others. So for interventions, what should we use with this?
Don't praise them.
Observation.
Don't praise them. Observation. Okay, we switched over to communication, now interventions.
Oh,
We'll do communication. We'll do communication. Communications, don't praise them, use observation. What else? Don't confront them, and don't explore them.
This is where you use I as yourself. I don't like what you did. I don't like this.
They're narcissistic. They're not going to like that you've now put them. I notice you have a problem with this report. They're not going to like that, but it is a therapeutic separating yourself from them. Make sure it's going to give them a self-awareness. Makes him see what you see. If you have this kind of boss, how would you make sure to verify they're not going to take something from you in reports? Date it. Okay, for nursing interventions, we want to use self-awareness to avoid frustration and anger. This is more for nursing interventions for the nurses. Use self-awareness to avoid that frustration and anger towards that patient. Do not internalize the patient's criticism of him or her. We do not accept their verbal abuse. So if they just kind of come up upset, I was, that you weren't here when I was supposed to wake up, and now I'm late for group. What do we say?
You got your own alarm clock.
No. You just say.
I'm trying to be Sherry.
You say, I was here, but I let you sleep.
No,
I figured it would be better for you to sleep.
I was here, but you were asleep. But you can say, I was here, you were asleep, letting them know that they were doing something. What's the ultimate goal when we're communicating with these patients? We want to gain cooperation from them. We want to teach the patient in a matter-of-fact manner. We also want to set limits to their verbal abuse, if necessary. I have feelings too. So if narcissists are all about, all about how they feel, controlling others, you don't give them what they want. You kind of set yourself and say, this is how I see things. All right. Avoidance. So what's the avoidance?
They're timid.
Shy.
That's Milton.
They're fearful.
Fearful. Do they want relationships?
Yes.
Yeah.
What is the difference between an avoidant and a schizoid? These guys are fearful. They don't really deal with social situations necessarily. What's the issue here?
Avoidant wants social interaction, whereas schizotypal doesn't want anything. They want to be by themselves.
They're shy and they have a fear of rejection.
Yep. They avoid contact then. They fear that negative evaluation beginning in early adulthood. They preoccupy with what they perceive as their own shortcomings, will risk forming relationships with others only if they believe acceptance is guaranteed. They see themselves as unattractive and inferior, often inept. What's their self-esteem like?
No.
It's usually inhibited as a child as well. Reluctant to take a risk for fear of being wrong. Fear of rejection, criticism, shame, disapproval. They kind of don't want to deal with any of that. How are they at working?
They're hard workers, aren't they?
They're good workers.
Very good workers. They want that approval. And they're normally going to get that approval unless they get what type of boss?
A narcissistic boss.
Nursing interventions. What would we want to do for them? What would we want to say to them?
Encourage, praise.
Praise them, support them, reassure them. Psychotherapy is best. Help them explore their positive self-aspects, positive responses from others, and positive reasons for self, and watch for reasons for self-criticism. What else could we do, like clothing-wise, for them?
Show them how to fit in.
I might have a harder time with that. Showing them how to do that. Teach them social skills, teach them positive talk. What's going to happen to this patient if they have a narcissistic boss? Specifically with their self-esteem.
Tear them apart.
Yeah. Their self-esteem is going to go farther and farther down, so they're going to work harder, and they're going to work more, and they're going to work more, try and get it back, and it's going to get back. Avoidance, the avoidance is one of those terms where if you start thinking about the terms, it begins to all fall into place. All right. Now, cluster C. Dependent. Clingy, indecisive, and submissive. So, how would you define a dependent?
Those are the clingy ones. They depend on you for everything.
Pervasive, excessive need to be taken care of, leading to submissive, clingy behavior and the fear of separation. What other personality had that fear of separation? Mommy.
Is it borderline?
Borderline. Constant fear of that separation. Fear of separation. They're not going to be making decisions. They're not good at it. They're not going to do anything for themselves. These are the ones that kind of hold on and sit behind people. Need of approval to others to a degree that they have great difficulty making independent decisions, starting projects. They feel helpless when they're alone. What do we need to tell them to do? Make a decision. We need to get them to make decisions. If they're not making decisions, we need to get them to make decisions. As a child, they were probably overprotected. So how many friends did they have?
None.
They probably did a lot of stuff alone. What type of relationships are they probably going to be in?
Probably abusive.
Abusive. They're going to stay in it and try and maintain any relationship, even if it's abusive. They need to care for others. And if they're placed as an authority so that they want to be loved, and now they're authority over people, what's going to happen? This person who wants to be quiet, be accepted by everyone, but sits back, is now in charge of everyone. What do you think is going to happen?
They're going to be scared to death.
Yeah, they're anxious, extremely anxious. We need to allow them to make mistakes as a child, so they'll allow them to actually have growth. Nursing interventions for these people.
Help them make a schedule.
Yeah, help plan daily schedules. Help them
Express feelings.
What?
Express their feelings.
Help them to express their feelings of grief. Them lose failing relationships while fostering autonomy and self-reliance. Get them to get on their own. Help to identify their own strengths and belief in themselves. Use reframing techniques. Redirect positive behavior.
So do you think the dependent and the borderline would make a good couple?
Pull away, pull away. No. Oh no! I don't want to know, I don't care to do it. No, I'm not even doing that, no. I think a narcissistic and a borderline and a dependent would make a good couple, but for bad reasons. All right. Obsessive compulsive, our last C. So what are we going to see in obsessive compulsive personality?
They want to be perfect.
Perfectionist. What else?
Their way or no way.
Rigid. Their way or no way. Control is good. That's what they want. Perfectionism, rigidity, controlling, extreme orderliness. Everyone around them needs to follow their way. How many friends do they have?
Not very many. People can't handle them. Rigid
perfectionism often results in that indecisiveness, preoccupation with detail. They are constantly obsessed with something. So what's their mood and affect? What would the affect be?
So flat and blunt.
Yeah, they are constantly, how do I make this more perfect? Just think about it. There's 30 things going in their mind of what they can make perfect. They're going to be thinking about that. Flat, blunt.
So
Hoarding is.
I think they worry though, don't they? Aren't they constantly worried?
They may appear depressed. Difficulty being.
Well, I wrote from her thing. They worry continuously.
Well, they would be worrying about continuously to make sure they have constant perfection, because they'll probably never reach it. They're always harsh, critical, and judgmental towards others. So yeah, they would be constantly worrying about things. Their rigid perfection results in indecisiveness, preoccupation, and insistence that others do their things their way. How are they at work?
Good workers.
Very detail-oriented.
Well, depending on the job, they also may have an issue.
They may start tasks and not complete them.
Yes, it just depends on the job. They may have a very good job if they have, if they need to be a perfectionist, great. If they can make, one statue a year and sell it, sweet. But if they have a job that they have to make 30,000 items in a day, just doing something, and it's got to be not perfection-driven but item-driven, they could probably have a problem with that.
Don't they also not work well in groups?
No, because people can't deal with their rigidity.
Yeah.
So I guess that would be more along the lines of people can't deal well with them. They always have that thought of they could have done better. They have difficulty maintaining that lasting relationship. They have very few friends and little social life. They're at work. They may be successful because of the need for precision and attend to detail, but have problems working collaboratively. It just depends on what job it is, as we said. So when we're treating any disorder, when we're dealing with these types of things, if we're giving a medication, we've reached therapeutic level and something like the obsessive compulsiveness goes away. But what's going to happen if we take those meds away? They stop taking them.
They're going to go.
Comes back.
Yeah, that comes back. Now, we can give SSRIs for this, psychotropics to help them sleep over the benzos.
Is this the guy that she also talked about constantly checking to see if the garage door is closed, like having to drive around the block 10 times?
Obsessive.
Mm-hmm.
Mm-hmm.
Yeah, washing hands.
Washing hands, etc. Yep. Help that patient view decision-making differently. Set the goal to complete the project rather than goal of perfection. So you have this project, complete it. Doesn't matter that there's an odd number of nails on one side versus the other. Doesn't matter this versus that. Get it done, and you're done. That's your goal. Help them set those goals. How would you encourage them to take a risk when it comes to something like that?
Let somebody else do it for a change.
Let someone else do it. Let it go.
It doesn't need to be perfect.
Mm-hmm. Now, communication. How do we talk to them?
Praise, positive, and observation.
Yep. What do we not do for them? Do we confront them?
No.
And we do not confront them. We do not matter of fact. Help them with scheduling, but we don't tell him to stop doing things. We set goals. Help them. All right, other related disorders. Depressive. That continued feeling of sadness or gloom, blunt, dejected affect. They're going to express unhappiness, hopelessness, regardless of the situation. They can't relax or do hobbies. It's just like our major depressive in a very minute pattern. They don't really enjoy anything. Sadness, depression, gloomy, blunt effect. Unlike that, though, they have a depression unrelated to a situation or disease. If it's only related to a situation, what would it be then?
Situational or major depressive disorder?
Dysthymic.
Well, they can be dysthymic without there being a reason. Dysthymic is just a lowered mood.
Quote, only related to a situation, dysthymic. And this is actually when she was talking to you.
Yeah, but for this one, they don't have a reason. There's nothing wrong with their serotonin levels.
Right. I'm just saying, not depressive, but a secondary, just a tangent. Depressive, dysthymic, over here. Dysthymic, if you're only related to a situation, you could think of dysthymic. Something else is going on.
No, that's depression. Double check your dysthymic definition. I'm just saying. That's not, I said it. I asked, so that means that they're just like dysthymic, and she said yes. So she compared this to dysthymia for a patient. So just be careful in terms of that.
Okay. Dysthymic is the idea of not being strong enough for it to be major depression. So I guess you could say, okay, I can see that then. That does make sense. So our depression, our depressive disorder could be thrown into dysthymic, but this is a other related disorder. Continued feelings of sadness, gloom, blunt, dejected affect. Okay. Yeah, I guess I can see that.
Just saying, at Mayo Clinic defines dysthymia as a mild but long-term chronic form of depression.
Which would be like this, because this is chronic and long-term, but no known cause.
Right. So yeah, I see. Now I can see what you meant when you said that. Let me just fix that. Thank you. That's what we're here to do. So dysthymic is that not strong enough to be considered major depressive, but still depressive. So good. Yay! One more connection. Cannot relax. Do not enjoy the hobbies. Same as those. Unlike they have depression unrelated to a situation or disease, though. Will they respond to antidepressants or psychotherapeutics?
SSRI, Lido.
They will respond to those. What's their self-esteem going to be like?
Low.
Yeah, and overly passive. What's their serotonin levels like?
Normal.
They're normal on lab work.
Yep, but SSRIs still work for them?
Yes.
Yes, they do. Nursing interventions for depressive. What do we assess for?
Suicide.
Suicidal ideation. Well, if we assess for suicide, we're late.
Okay, point taken.
So how about risk for suicide?
Yeah, but, well, that would be a nursing intervention, but we assess for suicidal ideations. Are you feeling like that? Okay, let's see if you have a plan. Do you see what I'm saying? You assess for, if you've assessed for suicide, we might want to get a coroner to assess that suicide. Terminology. Assess for suicidal ideations. Again, we can go ideations, plan, and then, you know, go from there. Because we actually saw a question so far that actually said assess for suicide. We're like, no, you don't do that. And report feelings of the patient. They're depressed. What can we encourage them to do?
Talk about their feelings.
You want to have them do hobbies and stuff, right?
Yeah, get them in multiple activities. To be hobbies.
Positive things.
Positive.
multiple positive. Yeah, don't get them on heroin or anything, but get them in multiple activities. Stop them focusing on their negative thinking. You train, get them to do something, but positive things to help them stop focusing on it, keep them busy. Give factual and feedback and positive information about improved behaviors. Teach them effective social skills, such as eye contact, attentive listening. The last one is our passive-aggressive disorder. What's their attitude going to be like if they're passive-aggressive?
It's kind of like negative.
Negative, defeatist, sullen. Oh yeah, I guess we can do that. Yeah, passive-aggressive, pervasive attitudes, negative, sullen, defeatist. Mood fluctuates rapidly, erratically, and they can be easily upset. Experience extremes conflict between dependence and other symptoms, and desire up for assertion. Complains they are misunderstood and unappreciated by others, but they can also have a high amount of jealousy for other people. They are resentful, and opposition occurs when working with others. They can even obstruct the other's work efforts, even when they're working with them. What's the difference between someone like a narcissistic and a PAD?
Narcissist wants to hurt you, they don't care. Whereas PAD, they don't necessarily intend to hurt you.
Yeah, they don't realize, yeah. Misplaces your glasses and sitting on them by accident versus oops. I just put in my hand and said, smash them for you. They look better this way. Nursing interventions. We're going to talk to them. We want to help that patient. Help them examine their negative feelings. They may not recognize their feelings, so we can explore that. Examine the relationship between feelings and subsequent actions. Help patients to express feelings directly. Write down feelings or role play. Help patients control behavior responses. So somebody who happens to make a bad schedule test, no time off, no taking children without a house, or should be out of the house during study time. There's our personalities. The last ones are the ones that get a little finicky, especially that depression, because as you know, the dysthymic with Alex. Thank you for confronting that with me. I didn't quite get what she said versus what we have now, but that makes a lot more sense knowing chronic and dysthymic, and then putting it with the depressive personality. It makes more sense. So, just as a quick review before we go on to it, what are our two big things for A?
Odd and eccentric.
Odd, eccentric. And the three names?
Paranoid, schizoid, and schizotypal.
Schizotypal. Yep. Which one is related to a schizophrenic?
Schizotypal. Typal.
Schizotypal. Now, we go into that, and A are the weird ones when we're talking about them. They're the ones who don't really care about that, right? They don't really care about people caring about them or getting in with people. Which one of it, A, B, or C, can be medicated for their treatments?
A can be medicated.
C.
Is it?
C is the one that can be, all of C can be medicated.
A will not be medicated.
There are little bits
Fear
of
and
A and
anxiety,
B.
right?
Yeah, fear and anxiety. That's the big thing. Fear and anxiousness. Now there's a little bit of B, there's a little bit of A, a little bit in B that can be medicated, but all of C can be medicated because you have to think of fear and anxiety. We have things for fear. We have anxiolytics. All of C has the ability to be medicated. There's a little bit of A, there's a little bit of B.
Okay.
In B, what are our terms for B?
Antisocial, borderline. How do you say the H word? Histrionic and narcissistic.
Narcissistic, yep. And they're dramatic and they're emotional. Okay? Which one of them wants to be loved by everyone and does everything they can for everyone?
Histrionic.
Histrionics. Which one of them wants to be loved by everyone but pushes everyone away at the same time?
Borderline.
Borderline. Which one splits staff?
Borderline.
Which one sees everything as good and evil only? I think you're muted.
Borderline.
Yes. Again, think of your borderline as a literal borderline with the mom at the end, and a lot of your stuff falls into that picture. Okay. We've just done the personalities. I say we take a 10, and we'll jump into questions for those who wish to look at them, because they're not that bad. Honestly, a few of us have seen them. They're not bad until you start actually having to think about them. But to recognize them are pretty easy. But actually treating them are a different story. So let's take 10, and then we'll start working on them. There you go.
There you go. Half time.
It's a 10-minute break, so it's 10 minutes of this.
Now let's see that in reverse.
Let's see that. It's in slow-mo. It's a replay. Oh, now we have to see that part.
Oh, where he's coming out of the rhino. That's.
Oh, yes!
Oh my god.
That space gonna be like scarred.
What? What?
Oh my god.
It's an HD. It's an HD.
He starts tapping the fan because it goes. Like, what? Oh yeah. Chink. Chink. No. I'm giving her all she's got, Captain.
Oh no. Look, look, look!
Look! Look! Oh, I think it's a baby rhino. Yeah.
How much longer we got, Dave?
9 o'clock.
Well, no, I meant for break.
This video is actually timed perfectly.
That didn't help me, and that didn't answer the question. Okay.
About a minute.
Oh man! Oh.
That was too good. Okay. Let me get this up.
Yogurt looks like a peasy one.
All right. You guys ready?
Yep.
All right. Our wonderful, gigantic 58-page paper. Boom! Isn't it pretty? Let me just open it up so you can see this.
Oh, wow.
What is that?
Nice. It's 58 pages of nursing questions.
That's it, David? Just 58?
Well, that's 58 before pediatrics.
Let's not go there.
We'll be going there. Don't worry.
Yeah.
I thought you were in the bathroom.
There we go.
I can't even read those, Dave.
But I'm zooming in. I was finding it. All right, we're going round and round like we always do. Alex gets to go first. Sherry, you're not even on the end this time. All right, here we go. Let me actually get a hold of the volumes, though, so in case anybody's having any issues. Alex. Which predisposing factor would be implicated in the etiology of paranoid personality disorder? The individual may have been subjected to parental demands, criticism, and perfectionist expectations. The individual may have been subjected to parental indifference and passivity or formality. The individual may have been subjected to parental bleak and unfeeling coldness. The individual may have been subjected to parental antagonism and harassment.
Antagonism and harassment.
There you go. Going backwards. Amy.
Yeah.
The nurse is assessing a client diagnosed with borderline personality disorder according to Mahler's theory of object relation, which describes the client's unmet developmental need. The need for survival and comfort. The need for awareness of external source of fulfillment. The need for awareness of separateness of self, or the need for internalization of sustained image of love to object or person.
Are these questions English?
This is not. This one I left in here just to make you think.
4. 4.
No. 4, 2, and 1 are all dealing with mom, but 3 is making you read. It was the idea of you have to separate yourself, becoming independent. It's borderline.
3.
Yes, it's 3. Jennifer, are you there?
I'm here.
Okay, I was making sure. Using interpersonal theory, which statement is true regarding development of paranoid personality disorder?
Let me come on. Look at my nose. It was itching. And
Studies have revealed a higher incidence
brutal.
of... Who's talking?
It's red on the end.
That would be April.
That would be April.
April says she's got a pimple on the end of her nose. And it's your
Okay.
fault, Dave.
Okay.
I heard.
Question, recording.
Well, you asked.
Studies have revealed a higher incidence of paranoid personality disorder among relatives of clients with schizophrenia. Clients diagnosed with paranoid personality disorder frequently have been family scapegoats and subjected to parental antagonism harassment. There is an alteration in the ego development so that ego is unable to balance the id and superego. During the anal stage of development, the client diagnosed with paranoid personality disorder has problems with clients within his or her environment.
Number 2.
Look at you! Look at you!
Yay!
Hey, Jenna.
Yes.
We get to have breakfast tomorrow. A client diagnosed with narcissistic personality disorder has a grandiose sense of self-importance and entitlement. When confronted, the client states, contrary to what everyone believes, I do not think that the whole world owes me a living. This client is using what defense mechanism? Minimization.
Denial.
Denial, rationalization, or projection.
Denial.
Is not just a place in the river. It's the answer.
Not just a river in Egypt.
Not just a place in the river.
He's denying that he said that wrong.
Totally. totally said it the way it's supposed to be written. Mike. Client diagnosed with borderline disorder ingratiatingly requests Valium. When the emergency department or physician refuses, the client becomes angry and demands to see another physician. What defense mechanism is the client using? Undoing, splitting, altruism, reaction formation.
I'm thinking it's 2.
That's it. Robert. Peculiarities of ideation, appearance, and behavior, and deficits in interpersonal relationships is the schizotypal personality disorder. As a pervasive pattern of excessive emotionality and intensive seeking behavior is 2. Borderline personality, histrionic, paranoid, or passive-aggressive.
Histrionic.
Yes. Sherry. Look at you guys already going at this. A diabetic client admitted to a medical floor for medical stabilization has a history of antisocial personality disorder. Which documented behavior would support this access to diagnosis? Labile mood and affect and old scars noted on wrist bilaterally. Appears younger than stated age with flamboyant hair and makeup. Began cursing when confronted with drug-seeking behaviors. Demands food prepared by personal chef to be delivered to room.
Antisocial.
Oh. I'm down to 2.
Three?
Ding. You got it. Paranoid. Yeah, no. Where'd it go? Where'd it go?
It's 7.
Yeah, 7 is 3. Antisocial personality is characterized by a pattern of socially irresponsible, exploitive, and guiltless behavior. So you're confronting them. They're upset about that.
I got that one way wrong then, because I
What
had.
did you say?
I was thinking 1 or 4.
4 is narcissistic.
These
Well,
people want to be the Barney BAs, so that's why I said cursing.
Yeah,
Well,
oh my goodness.
The only reason I'm thinking 4 is because I'm like, they're the ones that they live with mom and they want mom to cook them dinner every night, you know, and bring it to their room.
Well, those are, well, remember, with 1, one is borderline. They're labile, they go back and forth. That's borderline. Narcissistic is 4.
Well, that's why I was down to 2, but I never would have thought 3.
I didn't think antisocial was the one that lived with mom.
Mm-mm.
Mm-mm. Yeah. Antisocial is not necessarily the one that lives with mom. I was trying to figure out what you meant by that.
What am I thinking of that lives with mom?
Schizoid.
Oh.
Schizoid.
Oh,
Geek in
schizoid.
the basement.
I get those confused because
I know. That's why we need to find
Yeah.
the ones that confuse you, and we're going to separate those out while we're studying. So those ones like that, that's one you need to write down, and we'll get those separated. Narcissistic, everybody should have, but
Yeah.
schizoid, schizotypal, and you know, when you think about them, you don't. When you start seeing them like this, you may get them confused. You won't realize you'll get them confused.
Mm-hmm.
7. What are we on? Tesfaye, you there?
Yes.
All right. A diabetic. Let's see, we did that one. Irresponsible, guiltless behavior is to a client diagnosed with cluster B. As avoidant, dependent behavior is
answer one more
to a
question.
client diagnosed with cluster A, B, C, or D.
That's C.
C, yes. Seeing how one of them is called dependent.
And avoidant.
And avoidant.
Yeah. A client diagnosed personality disorder tells nurse, when I was the waiter, I used to spit in the dinners of annoying customers. This statement would be associated with which personality disorder? Paranoid personality disorder, schizoid personality disorder, passive-aggressive personality disorder, antisocial personality disorder.
Is this me?
Alex.
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 Sorry. Passive aggressive.
Passive aggressive. Right. Why wouldn't it be antisocial?
Because they're not going to be a waiter in a restaurant.
If it was antisocial, they'd just spit on the person themselves. They wouldn't just spit on the
Exactly. They were like, oh, you don't like that? Smash on your head.
Well, antisocial typically wouldn't be a
waiter.
A waiter at a restaurant.
Yeah. But you never know.
Yeah.
Amy?
Yes.
Client diagnosed with a personality disorder insists that a grandmother, reincarnation, has come back to life as a pet kitten. This one's totally a Jenna question. The thought process described is reflective of which personality disorder? Passive-aggressive, schizotypal, borderline, schizoid.
Schizotypal.
Yes!
Yeah.
They can have peculiarations, ideations, appearance, and behavior, magical thinking. They currently are having magical thinking.
Nick, you're Junior.
Jennifer. John. The client is diagnosed with personality disorder. States you are the very best nurse on the nurse, and not at all like the mean nurse who never lets us stay up later than 9. The statement would be associated with which personality disorder? Borderline, schizoid, passive-aggressive, or paranoid?
Borderline.
Borderline.
Whoa! Connections are being made. Look at you guys going fast. Jenna. A male client diagnosed with a personality disorder boasts to the nurse that he has to fight off female attention and is the highest paid in his company. These statements are reflective of which personality disorder?
Can you read a little bit slowly, please, David?
What?
Can you read a little bit slowly? You are too fast for me.
Of course. A male client diagnosed with a personality disorder boasts to the nurse that he has to fight off female attention and is the highest paid in his company. These statements are reflective of what personality disorder? Obsessive-compulsive,
Yep, that one.
passive-aggressive, schizotypal, or narcissistic?
Narcissistic.
The San Francisco
retreat. That was really sad. Mike, a nurse encourages an angry client to attend group therapy. Knowing that the client has been diagnosed with cluster B, which client response might the nurse expect? Sarcastically, that group is only for crazy people with problems. Scornfully, no, can't you see that I'm having a seance with my mom? Suspiciously, no, that room has been bugged. Hesitantly, okay, but only if I can sit next to you.
Oh. 1.
Yes. Which one is it representing?
Like all of them in B?
It's showing antisocial. Expletive, guiltless behaviors. Bummer.
I can see narcissistic.
Like
Saying
I said, he's a narcissist.
Oh, we're in Group B.
But
well, Group B is narcissism. Excuse me.
yeah, narcissistic.
I was like, wait,
also.
Group B is narcissism. So yeah, it's a little bit of that one. So that would make sense with that too. I'll just read it specifically. In the question, the client's statement would represent a typical response for someone who's diagnosed with antisocial. These clients also display patterns of socially irresponsible, exploitive, and guiltless behavior. It includes antisocial, borderline, histrionic, narcissistic. Client diagnosed with cluster B exhibit behaviors that are dramatic, emotional, or erratic.
You cut out on me. I didn't hear which question you were.
Well, I was reading them there. 14. A client diagnosed with borderline personality disorder is admitted to a psychiatric unit with recent self-inflicted cuts to both arms. Which of the following would explain this behavior? Select all that apply. Self-mutilation is a manipulative gesture designed to elicit a rescue response. Self-mutilation is often attempted when a safety plan has been established. Self-mutilation proposes that feeling pain is better than feeling nothing. Self-mutilation results from feeling of abandonment following separation from significant others.
There's also 5, Dave.
Self-mutilation is excuse me, I was trying to drink something.
Oh.
Self-mutilation is attempted when voices tell the client to do self-harm.
Yeek.
All right.
1, 2, 3, 5.
Abandonment on separation. That's attention. One, two, three.
And 4.
What? Not 5?
5 would only be if they had a comorbidity like schizophrenia.
So it's what? What's the answer again?
1, 2, 3, and 4.
Okay, so okay, because
borderline does not have voices.
Ah.
Now, if it had voices, that would be part of it. If they were schizophrenic.
Well, I wasn't even reading that part. I'm thinking which of these would be true for somebody who's self-mutilating.
Yeah, you got to think self-mutilating and borderline.
Yeah.
Robert, you did all of them but the 4. Feeling of abandonment, and I'll read that to you. Clients diagnosed with borderline fear abandonment, which is frequently part of their past history. The pain of abandonment is intolerable, and the client seeks relief by experiencing the physical pain of self-mutilation. So, I cut myself to feel alive.
I forgot about this.
It's all that apply.
Oh.
More attention seeking. I forgot about.
All right. Sherry, you there?
Yes.
It was
client has been diagnosed with a cluster A personality. Which client statement would reflect cluster A characteristics? I'm the best chef on the East Coast. My dinner has been poisoned. I have to wash my hands 10 times before eating. I just can't eat when I'm alone.
2.
2.
That was the one I was going to guess, and that's right.
Because they're paranoid.
Yeah, like, C, yeah.
Cluster A's are paranoid. Sorry, my wife is trying to answer these questions also.
Tesfaye.
Yep.
Personality disorders are grouped in clusters according to behavioral characteristics. In which clusters are the disorders correctly matched? Cluster C, antisocial, borderline, histrionic, narcissistic, anxious or fearful. Cluster A, avoidant, dependent, obsessive compulsive, odd or eccentric.
Nope.
Cluster A, antisocial, borderline, histrionic, narcissistic, dramatic, emotional, erratic.
Nope.
Cluster C, avoidant, dependent, obsessive compulsive, anxious, fearful.
I think it's 4.
Yep, someone fits.
It's 4.
Okay.
I'm going to be leaving soon to go to dinner, Dave.
Again?
Well, we were planning to be gone tonight, so we didn't plan anything to eat.
Oh, okay.
So we're going to go get some food.
Oh, okay.
Yeah.
All right.
Yeah, April said you're welcome to join us.
Okay. You want to wait till 9?
He's studying till 9.
We all come.
Yeah.
We can all come if you can wait till, I'll say, I'll cut it at 8:30.
Everybody can come as long as they pay for themselves.
What the hell's the point in that shit?
Let's see. Alex, let's jump down to the ones that I want. Let's see. Actually, we're at the good ones. Which scenario would the nurse expect to observe if the client were diagnosed with disorder? At lunch and states everyone wants to hurt me. Client is irresponsible and exploits other peers in the milieu for cigarettes. Client is shy and refuses to talk to others because of poor self-esteem. Client sits with peers and allows others to make decisions for the entire group.
1.
1.
Look at that one. It's all fast and dirty.
Thanks for the gimme.
Yeah, I know.
You're
That's
welcome.
my question.
Amy. According to the DSM-4, which diagnostic criterion describes schizotypal personality? Neither desires nor enjoys close relationships, including being part of the family. It's preoccupied with unjustified doubts about loyalty or trustworthiness of friends or associates. Considers relationships to be more intimate than they actually are. Exhibits behaviors or appearance that is odd, eccentric, or peculiar.
Four.
4. Which one would be 1?
Schizoid.
Yes. Jennifer. According to this manual, which diagnostic criterion describes schizotypal
No, that's what we
personality
just
disorder?
did.
I did that one. According to that manual, which the following criterion define borderline personality disorder? Select all that apply, Jen. I know, they're fun, aren't they? Arrogance, haughty behavior or attitude, frantic efforts to avoid real or imagined abandonment, recurrent suicide, self-mutilating behaviors, unrealistic preoccupation with fears of being left to take care of self, chronic feelings of emptiness.
Oh, this one sucks.
I would say definitely 2 and 3. And five.
That's it.
Okay, so would 4 be dependent?
Yes, it would.
Okay. Yay!
It was 2, 3, and 5, correct?
Yes,
What's
it was
the answer?
Okay.
What's the answer?
2, 3, and 5.
What is 1? Who's arrogant? Is that narcissistic?
Yes.
That's what I'm thinking. Narcissistic is 1.
Yep.
Okay.
Jenna.
Is 4 dependent?
Oh, wait a minute. I'm looking at the wrong ones. Oh, there it is.
All right.
What's 4, Dave? Is that dependent?
Yeah, that was dependent.
Okay.
All right. Jenna.
Mm-hmm.
According to that manual, what's the following diagnostic criteria to define avoidant personality? Select all that apply. Does not form intimate relationships because of fear of being shamed or ridiculed. Has difficulty making everyday decisions without reassurance from others. Is unwilling to be involved with people unless certain of being liked. Shows perfectionism that interferes with task completion. Views self as socially inept, unappealing, and inferior.
One is true. Three is true. And 5 is true.
Yes! 2 isn't true because it says making decisions. They'll make decisions, they just have a problem of doing things on their own. Not necessarily making that decision.
I thought avoidance worked well.
They do work well.
Yeah, they just have a difficulty. They don't have it. That's why 2's not part of it. They have.
Okay.
They don't have a hard time making.
I thought you said they had a hard time doing things, and I was like, I thought they were really.
No. I'll read it to you carefully. Clients diagnosed with dependent, not avoidant personalities are unable to assume the responsibility for making decisions. They have problems with doing things on their own and difficulty initiating projects. I was still talking about the
Yeah, I got you.
Sorry, Mike.
Well, what is 2?
I just said that.
That's dependent.
Dependent?
Yeah.
Now
Mike.
I'm confused. What was the answer to that one?
1, 3, and 5.
1, 3, and 5. Yeah.
Okay.
Because 4 would be the obsessive.
21 is Dave.
Mike, when assessing a client diagnosed with histrionic, the nurse might identify which characteristic behavior.
Four.
Odd belief in magical thinking, grandiose sense of self-importance,
4.
occupational orderliness, or attention-seeking flamboyance.
4.
How do you know?
Because it's Dave.
It's me! Yeah.
Oh my gosh, my dog keeps stealing stuff.
Robert, when assessing a client diagnosed with passive-aggressive, the nurse might identify which characteristic. Exhibits behaviors that attempt to split the staff, shows reckless disregard for the safety of self or others, has unjustified doubts about the trustworthiness of our friends, seeks subtle retribution when feeling others have wronged them.
4.
I was like, that's the definition. Sherry, although there are differences among the 3 personality disorder clusters, there are some traits common to all individuals diagnosed with personality disorders. Which of the following are common traits? Select all that apply.
I want this one. It's select all. Okay.
Failure to accept consequences of their own behavior. Self-injury behavior. Reluctance in taking personal risk. Copes by altering environment instead of self. Lacking of insight.
Hey guys, I'm gonna be right back.
Two.
So, what you're saying is every personality type cuts themselves.
1.
It doesn't. It just says injury.
All 3 personality disorders.
Okay.
What are common traits of all 3 personality clusters?
Well, apparently 1.
Failure to accept. Yeah, they all like what they are. They all are who they are. There's 1.
4.
Good.
Oh Lord.
What about 5?
Are you done there, or is that good?
I
thinking
have no
1.
idea. I always pick too many or not enough. So
I'm thinking 1, 3, 5.
I think 5 should be right.
I think it's 1, 4, 5.
I was gonna say, Mike, 3, reluctance in taking personal risks. 1, 4, and 5.
Well, I'm thinking personal risk in your personal life, not like I just overthought it.
Anti-social.
Yeah, I overthought it.
Yeah, anti-social. That's all I'm gonna say about that one.
Yeah.
Failure to accept consequences for own behavior. Copes by altering environment instead of self, and lacks insight. So, for a common trait among individuals with personality is their response to stress. When feeling threatened, the individual copes by attempting to change the environment. So 1, 4, and 5 is correct on that one. Now, I've got something special for, let's see, we just did that. Let's see, that was Sherry. Tesfaye, you ready?
Okay. Real slowly, okay?
Client diagnosed with antisocial states, my kids are so busy at home and school they don't miss me or even know I'm gone. Which nursing diagnosis applies to this client? Risk for injury. Risk for violence, self-directed. Ineffective denial. Powerlessness.
I don't know. Is it number 1?
No.
No?
They mention nothing about hurting themselves. Nothing presented is about harming themselves. The answer is 3, ineffective denial. They're doing the conscious or unconscious attempt to disavow knowledge or meaning of an event to reduce anxiety.
So
They're denying the children's need for parental support by turning the situation around and making themselves sound like the victim.
Oh, okay.
Oh, poor me, poor me.
Wow.
All right, Alex, you ready for the fun ones?
Yeah, I'm back. Let's go.
You said
All right,
these
let's
are
do
fun
this.
ones?
The fun ones. We all get one of these.
Oh.
They better be easy.
Oh, they are.
Yeah.
Absolutely are.
I'm
Oh,
leaving
the
after I
drugs,
answer
forget
mine.
it.
Oh, good.
No fucking nuts.
All right, Kat, let's do it.
Are we doing math?
Math.
No.
I don't have a calculator with me.
And look, they're multiple choice.
Jerk.
I made it easy. Alex, go for it. Heparin, 6,500 units. IV push has been ordered. It's available at 15,000 units. How many mils should be given? No, Harry Potter, shut the heck up.
.4 D.
D.
See, I can't see all the answers.
Well, I'll show you the answers then.
Well, screw you for giving me math.
You're welcome. I love you too.
Uh-huh.
Amy, you're up.
Yeah, me?
Erythromycin, 250 milligrams and 100 milliliters of D5W to
Oh,
infuse
really?
over 30 minutes. Calculate the milliliters an hour.
Oops. Sorry.
That would be...
This one's easy. You should be able to look at it and figure it out.
Mike, we're not all good at math
Mike.
here. Shut up.
You don't get to say Jack.
Well, no, I'm just trying to give you a hint. Like, this, anytime you see this, it makes it very easy to figure out this problem.
B.
It's
No.
C. Anytime you see 30 minutes, always double your mLs. That's all you have to do.
So if you double that, you have to double that. It gives you 200 mils an hour.
Anytime you see 30 minutes, always double your mLs, and you got your answer.
Because I was trying to double the milligrams.
That has nothing to do with equations. That's just extra information.
Mm.
You throw that out and you say, okay, 100 mils over 30 minutes times 6 per double.
C.
All right, Jennifer, your patient weighs 130 pounds. You are ordered to administer 15 mgs per kilogram for 24 hours of a medication, divided doses every 8 hours. How many milligrams of the medication would you give per dose?
B.
B. 295.
How the hell did you do that fast?
She already saw the equation.
Y'all saw the question, was working on it while.
Yeah. I was going to say, you can't do it faster than I can. You probably had a calculator and you were like, all right, 130 divided by 2.2 multiplied by 15 divided by your 3. And you're good to go. But,
So we said B was the answer.
yeah.
Okay.
Look at you. Jenna, it's math time. You ready?
No.
I'm here.
Math time, do. Medication order is to give 500 milligrams IM, Q12, available, 0.5 grams per 2 ml. How many milliliters would be administered per dose?
Really?
That one's
See?
that's not bad.
Hey, see? Mike. The epidural orders are to be turned to infusion and call the anesthesiologist if the systolic blood pressure is reduced by 25% pre-op baseline. Pre-op baseline was 138/84. Patient's blood pressure is now 102/64. Systolic has been reduced by what percentage? 20, 23, 25, or 26?
All right, hold on.
This one's perfect for you, Mike.
Yeah, it really is.
Words with friends.
6.
What?
It's going to be D.
Hey ho. All right, Robert, math time. A medication is available in 500 milligram tablets. The physician has ordered 0.5 grams. How many tabs should be given?
What the crap? How did I get that?
You're the one who keeps saying you're so damn good at math, Mike. That's
Hey,
not
Mike, I counted your windows.
You
How
probably
many we were
did.
in.
What a bunch of bull crap.
I'm sorry, Mike.
So, Robert, what do you got there?
1.
Hey! Sherry! Recognize this? A patient's ordered to receive 5 grams of glucose IV per hour. The patient has a 1-liter bag of D5W hanging. 1,000 milliliters D5W equals 50 grams of glucose. What would you put the rate per hour?
Oh my gosh, I can do this in my head. You give me the hard ones.
You're welcome.
Well, I don't even have a calculator, so go ahead and do it for me.
It's B. Take a 0 off of each, and you end up with 100 mLs and equals 5 grams, and you're doing it in an hour, so it's 100 mLs an hour.
Mm-hmm.
You see how you do that?
No, I'm visual. You'd have to.
If you're looking at if you've got 1,000 equals 50, and you take a 0 off of each, you have 100 equals 5.
Okay.
And you needed 5, so you know you have 100 mLs, and you need to do it over an hour, so it's 100 mLs an hour.
Mm-hmm.
Does that always work?
If you have zeros on the end of each of them, you can always take zeros off to simplify your equation. What I tell people to do, and I've said this numerous times.
Okay, yeah, we're going to do our 2 ways. Go ahead.
Well, I'm just saying, if you ever can't figure your problem out, figure out how many mLs are in, how many grams per ml. So if you can figure that out, you can always figure your answer out. So if you get that down to a base, like 1 gram equals 10 milliliters, you can always figure out your answer.
Okay.
Mommy, I know what I'm gonna have. Dad, did you teach all of them right?
What?
Did you teach all of them right?
Mm-hmm.
Is the math easy?
No.
Dave.
Oh, sorry, I was looking at something real quick.
Oh.
Where'd it go? Okay, here we go. Tesfaye.
Yeah, I
Your
can't
patient
see
has
the
been
question.
receiving 20 units of...
Hold on. Tessa was trying to say something to you, Dave.
What?
I cannot see the question. It's disappeared. I'm just listening.
Log out. Why can't you see? Can you click off of the thing and click back in?
I'm trying with another computer, maybe.
Hold on. There you go.
No.
You'd have to log out and log back in. We're almost done, so that's okay. Just have a listen. That's cool.
Oh,
You haven't seen these ones.
Okay.
Alex, Mac to math. Your patient has been receiving 20 units of Lantus, but now has become NPO. The order reads that if your patient is NPO, Lantus is to reduce by 20%. How much Lantus should you administer now that the patient is NPO? Isn't these fun equations, Mike?
Mm-hmm. Like these things that we would never get.
Yep. Well, you guys wanted math. I figured it'd be fun to warm up before I give you the actual ones.
See.
Yes. 20%. Base it on 10. That's 2. Double that gives you 20. 16.
Or you can take 20.
But none of y'all's ways work for me, so
No.
as long as I figured it out, it's all that matters. I don't care.
All right, Amy,
When you're dealing with percentages, it's always out of 100. So if you know 20 goes in, or if you have 20 and you divide it by
20
4,
times 0.2 is what gives
5.
you your answer. You subtract that from 20. I figured it. I got it.
Yeah.
Or you just multiply it by 0.8.
I'm good.
Right, but yeah.
Again, there's multiple ways to get the same answer. We all know that. Calculate the following percentage, Amy. 180 is blank percentage of 210.
D.
Yay! See, math. Math is fun. Math is grand.
Oh, we're done.
That's it. I'm not going to make you guys jump too much into this yet.
All right, I'm going to jump off here because I've got to go get food.
Go get food, senor. I'm going to get ready because I got to get up early. All right. You guys, thank you guys for coming on.
We're done?
Yeah, there's nothing else to pretty much hit because it's 8:40. We're stopping at 9, and we don't have time to hit a review or anything like that. Unless you guys want to do 20 more minutes of questions.
I have a question, David, for you. How can I download on the Hangout? David. Oh. David. David.
I think we all.
There we go. We're back.
There he is.
Server error. It happens.
David.
Server hiccup. Hold on. Server hiccup. We're good.
David.
I'm here.
How can I download Hangout on my laptop?
I'll tell you. Hold on. We're still recording, so I'll tell you in a little bit. We're getting everybody
okay.
back on.
Sorry. Okay.
Okay. Make sure you just need to download Chrome onto your laptop.
Oh,
first.
Chrome.
Chrome, and then download Hangouts, and you'll have it. All right. So yeah, it's 8:40. We can stop. We can stop here, or we can do about 20 minutes of questions if you guys would like.
I have to get up early too, so I'm probably going to hop off. What time are we doing tomorrow?
Tomorrow we're going to do the evening. I have to go up to a couple places, so hold on. Let's just end this. Good night, everybody. Woo!